With me is Robert Leahy, and he's a psychotherapist, researcher, and writer. He's the director of the American Institute for Cognitive Therapy in New York and clinical professor in Weill Cornell University Medical School. He has also completed his postdoctoral fellowship under the direction of the great Aaron T. Beck, the founder of cognitive therapy, and won the Aaron Beck Award for outstanding contributions to cognitive therapy. We'll also talk a little bit about your new book, Emotional Schema Therapy, which presents your own model of cognitive therapy and updating some of the traditional cognitive model. And you know, this interview is taking place on Sigmund Freud's birthday. He would be 160 years old today. So I think you're integrative enough to find that a good thing. So
right.
We're very happy to have you, Robert.
Well, thank you, Alexandra. I appreciate it.
So I would like to start off just by asking you if there was a specific important psychotherapy book or author that really made an impact when you were starting out as a student.
Well, you know, when I was starting out, everything was either psychoanalytic or Rogerian. There was some behavior therapy early on, but my early interest was very strongly in psychodynamic therapy. I probably read almost every book Freud wrote. I had a poster of Sigmund Freud in my room that I thought would impress my girlfriends, and I'm really glad I had that background, Alexandra, because I think that it helped me understand the complexity and depth that people display. So I would say actually the first book that really grabbed me was a book called Neurotic Styles by a guy named Shapiro, I think David Shapiro. And I think it was probably published, I'm thinking about 1965. And it was like an ego psychology, psychoanalytic approach and trying to understand the compulsive style, the histrionic style, the kind of styles of thinking and behaving and coping. It was psychodynamic, but it was that part of psychoanalysis that moved toward ego psychology. And what's interesting, Alexandra, is that Beck actually was a psychoanalytic psychiatrist, as I'm sure you know, and he viewed the evolution of cognitive therapy as coming out of ego psychology and psychoanalytic theory.
Yeah, there are authors I remember, like Karen Horney, that played a big role.
That's right.
Yeah.
Yes, right, yeah. And so that had an impact on me. I think another book that had a big impact on me was a book by George Kelly, that the Psychology of Personal Constructs, that was published, I think, in 1955, which I read early on in my graduate school education. And from my way of thinking, that was sort of the template for what eventually was cognitive or rational emotive behavior therapy. When Kelly's work came out, I guess it came out in the mid-50s, it was simply the right idea at the wrong time. That, it was all psychoanalytic stuff. There was some Rogerian work, and they viewed it as overly rational, which it might very well have been, but I think it really had an effect on my thinking about how people construct reality. Another thing that had an influence on me was Piaget's writing, because as I shifted from my interest in psychoanalytic theory, I became interested in developmental psychology and social development, and I was very much influenced by Piaget's writing, the construction of reality and all that. Piaget being a constructivist, the idea that children construct reality according to certain theories that they have about reality. And so my thinking is very much in that kind of way of thinking. How do people who are depressed construct reality, or how do people who are anxious construct reality, or how do we construct, or what are our theories about our emotions or the emotions of other people? And of course, Beck's book, Cognitive Therapy of Depression, and Cognitive Therapy and the Emotional Disorders, which I think were published in the Cognitive Therapy and Emotional Disorders, I think was published in 1976, and Beck's Cognitive Therapy, Depression in '79. Those had a big impact on me, a tremendous impact. And of course, working with Beck, shifted me into a more formal cognitive model. But I also think, Alexander, I was an English major for 3 years in college, and I read a lot of literature, I read a lot of philosophy, and I have to say that I think, people like Dostoevsky and Sartre and Heidegger and Kierkegaard, all of that had an influence. So if you read my recent book, Emotional Schema Therapy, it might be hard to pin me into one category.
Well, this makes total sense to me, because even the influences you bring in from emotion, focus therapy, and from German Selfhelp, there's also like a more like humanistic existential tone to it that I'm sure that you also have a little bit part of that.
Yeah, and so there is that, and again, I think in America, I'm not sure how it is in Europe, but in America, I think there's been too much emphasis on being happy, like a smiley face type thing. And so in my sense, in terms of my idea about emotional schemas or about life in general, is I'm influenced by, I would say, a theory of tragedy, that tragedy is, in my way, in my view, that there's a certain nobility in everybody, where there's certain necessities of life, and there's certain inevitable losses and disappointments that we go through. And so one of the things I say in my book, Emotional Schema Therapy, and there's an example. I had a patient, not a patient, rather. I was giving a talk, and the chairman of the clinical program came up to me, and he said, what you say is very meaningful to me, and I got to share with you, he said, that my wife died 6 months ago, and I still can't get over it. She had a very serious and terrible cancer, and she suffered for a long time, and we both realized that it was time for her to die, but he said 6 months, and we had been married for 40 years and had grandchildren and all that. He said, I just can't get over it still. And I said to him, I think when you love somebody for 40 years and they're part of your life, that I said, I actually hope you never get over the loss. I hope you're always able to remember the loss as just a very painful thing, but you're able to build a life large enough to contain that loss, and that it's not a matter of living a life that's free of suffering. My thought is that it's living a life that's worth suffering for. And I think a lot of people, and that's, I think, a tragic view, that tragedy is that there was something very valuable and meaningful that was lost. And I think all of us have tragedies in our lives. We lose our parents, we lose our friends, we lose certain things that are of great meaning to us. And not to feel sad, and to have the ability to remember the sadness and once again experience the sadness. We can't just simply close off the negative emotions. We have to have access to all the emotions. As you probably are aware, that my friend David Burns wrote a wonderful book called Feeling Good a number of years ago, which I think is probably the best self-help book that I've ever read. And I think David is brilliant. But as I began to think, over the years, I began thinking about what life is, that I don't think life is simply about feeling good. I think life is about feeling everything. And feeling everything is having, in a way, being able to legitimize emotions that are often viewed as emotions we should never have. So I'm starting to write a book on jealousy, for example, which I'm sure that is a universal emotion. I don't view myself as a particularly jealous person, but I can imagine situations where I could definitely feel jealous. So my view is that we should be able to have access and understand and be able to experience all the emotions without getting hijacked by them, without being carried away by them.
Yeah.
In other words, to acknowledge that I feel jealous, or acknowledge that I feel angry, acknowledge that I feel hopeless. All of us have those feelings.
What you're saying links, you've shared a lot of information already, and it links with emotional regulation also, I guess, with the ability to feel without completely dysregulating with the emotion. And
absolutely.
A lot of things popped up when you were talking. I hear about living a life worth living, an expression that 𝗵cie 𝘀𝘁𝗁 loves to use from dialectical behavior therapy.
Right.
And, linking what you just said to the broader cognitive tradition, I think some people might have maybe misrepresented, but I guess some cognitive therapists unfortunately did do this, try to reason people out of their feelings, in a way.
This is, I think that there's, I've been, over the years, I've heard many people criticize cognitive therapy for being overly rational, for not dealing with emotion, not dealing with transference, not dealing with countertransference, not dealing with resistance, not dealing with attachment issues. And I think initially, I had a loyalty to the Beck model, like, when you have a guru, your leader. Right. I would not attribute these beliefs to Beck. I think Beck has a great deal of depth. Beck is a genius. He's one of the most extraordinary intellects that I've ever. He is the most extraordinary intellect.
Let me just say it now, because my next question was exactly, I know you trained with Beck, and besides his cognitive theory and therapy, I really wanted to know what you think were the most valuable lessons you got from him.
Well, I think that I think Beck's model sort of came along at a time where areas of psychology in America were moving more and more toward cognitive models. So I used to be very interested in social cognition, that is, how people form impressions, how they draw inferences about other people, and so forth. And the concept of schema, for example, back in the 1970s, before Beck was writing about the cognitive model and the way he was developing the schema issues in the model. The concept of schema goes back actually it goes back to the 1920s with Bartlett and Piaget and other people. But so Beck's model, I was coming at Beck's model actually having a very strong background in social cognition, social psychology, in what's called schematic processing, in memory and impression formation and so forth. So when I began reading Beck, I thought, gee, this really does very much relate to the model of schematic processing. What I think was particularly valuable in being trained by Beck, I did a postdoctoral year at the Center for Cognitive Therapy, University of Pennsylvania, was every Wednesday we had what was called the anxiety seminar. And the anxiety seminar was led by Beck. And, of course, everybody was anxious at the seminar.
They were all using coping skills to go through that.
Well, we didn't have coping skills back then. This was before coping skills. All we had was just raw anxiety. And so what was particularly valuable about Beck is Beck actually taught the seminar with the Socratic method. And what he would do is he would ask questions. This was before he wrote the book on anxiety. This is back in 1982, and he was beginning to develop the ideas and write the book on anxiety and its disorders. What he would do is he would say, well, the patient feels their heart beating rapidly. Why does that bother them so much? How does that become panic disorder? And so, it would be a question and answer like a Socratic method, and which really appealed to me. And it made me, and that's kind of like that method, like, why does this bother? What is this patient thinking? What does it mean to the patient? That continues to this day to be the way I approach. I see patients, I see 23 patients a week. And so I'm constantly learning from my patients. So a patient, finds out that somebody is doing better than they're doing, and my question is, why does that make you feel bad about yourself? And so the Socratic method really helps you with each individual patient understand what that patient's construction of reality might be.
Mm-hmm, mm-hmm. This makes total sense to me. I was going to ask you, now that you've talked a little bit about Beck, maybe we could move on even to your own ideas about cognitive therapy, the things you try to introduce over the years. Typically, cognitive, the traditional model, at least, it's focused more on the beliefs. So the beliefs about people and others and the world, their future.
Mm-hmm.
Metacognitive therapy then came along with Adrian
Yes.
Wells. Yeah.
I'm glad you mentioned that. It's excellent.
Mm-hmm.
Excellent
So
work.
in the 90s, so beliefs about beliefs. And now
Right.
your work,
Exactly.
took that
Right.
and it's beliefs
Right.
about emotions.
Right. Yeah, and I'm glad you mentioned Adrian Wells because, first of all, I think Adrian is one of the great contributors to the cognitive behavioral models. And my work is very much influenced by Adrian Wells's work, and I owe a great deal of gratitude to him. And in fact, when I've shared my work with Adrian, he views it as part of the metacognitive model.
Yeah.
What's interesting, Alexander, is Adrian views it, this is very much part of the metacognitive model, which I agree, by the way. I think it's my model is what I would call a meta-emotional model, like thinking about emotion. And not only thinking about my emotion, but thinking about other people's emotions and what my theories are about their emotions and my theories about emotional control or whatever. So Adrian's model, I think, has been extremely valuable. The mindfulness model is of value. I don't see myself in that tradition or the ACT tradition, but I think my work is not inconsistent with it. Mm-hmm. Where my work, I think, differs from the mindfulness or the ACT model, which are, I think, primarily experiential models and of great value. My model is basically a social cognitive model, and what I mean by that is that it's a cognitive model in that I'm interested in the person's theory about their emotions. So, for example, my model of emotional schemas, everybody feels sad or angry or even hopeless at times. But the question is, what do you think next? Do you think that your emotion is going to last a long time? So the idea of the duration of emotion is a key thing. If I think that I'm sad, if I think I'm lonely, let's say, and I think, my loneliness is going to go on forever, then I feel hopeless, I feel helpless, I feel even more depressed, I feel more anxious. But what if I think of my loneliness as, I'm lonely for a few hours? Mm-hmm. So the belief in what I would call the duration of emotion, the belief in terms of the escalation or loss of control of emotion, my belief about the need to control of an emotion, my belief that my emotions are similar to those of other people. So, for example, when my mother died 30 years ago, I was very, very sad because I love my mother, and I want to be the kind of person who's sad about that. I don't want to be the person who just, brushes off that feeling. Yeah. So, in other words, viewing my emotions as human emotions, as you mentioned, the humanistic model, viewing my emotions similar to other people, viewing my emotions related to my values. I'm sad because I loved my mother and I've lost something very meaningful to me. Mm-hmm. I think another part of the theory of emotion is our ability to tolerate mixed feelings. I'm not sure what the Portuguese word would be for ambivalence, but having mixed feelings. Mm-hmm. And I had a patient a while ago who was in a very difficult relationship, that her boyfriend was far away and they had breakups, and she didn't know, was she going to get back with him or not get back with him? Was she angry, sad, whatever it would be. Mm-hmm. And she said, and she was ruminating. She was just dwelling on it over and over and over. And I said, what do you hope to get from your rumination? And she said, I want to figure out how I really feel, And I said, it sounds like you really feel ambivalent. That's how you really feel. So, and she didn't understand that ambivalence was a completely legitimate emotion. And it was holding two emotions simultaneously, which I think is also psychodynamic in a way. But I'm sorry, go ahead, Alexander. You want to ask something?
Yeah, sure. No, you were talking. I was remembering also your work from your self-help book, The Worry Cure, and I remember that you talk about this thing that with the worry, there's like this promise that something will come out of it.
Right. But, and so that, of course, is very much influenced by Adrian Wells's model about what's called positive view of worry, that my worry is going to help me solve a problem, or I'll get certainty and the whole thing. So my view, my model of emotion is, I think it's different from a mindfulness model, although mindfulness I think is very useful and can be incorporated in what I do. It's more of what your theory is. And along with that, it's like if I have a theory of my emotion, that these are emotions that I should not have, or I should always be rational. For example, that's a theory of emotion, which is totally irrational, that I should always be rational, right?
Exactly.
It's impossible. In fact, the word rational is derived from the Greek word ratio, which means to see things in proportion or perspective. It doesn't mean being logical all the time. So, but anyway, but if you think about these emotions that we have and how we think about the emotion, what our theory is of the emotion, which emotions are okay. For example, in America, the research seems to show that people in America think that jealousy is a bad emotion. They should not feel jealous. Whereas in Europe, that's an emotion that's more accepted, the idea of being jealous. Maybe there are more reasons to be jealous. I have no idea.
Maybe.
But, it's interesting that we have these, what I would call implicit theories.
That you'd say,
and that we...
You'd say we would construct also, of course, in a developmental way. Over the years, we would catch on to these theories implicitly, and we would start to dissociate or start to attach certain labels to certain emotions.
Right. Yeah, and of course, there are people who are alexithymic, who the alexithymic individual does not have a label for the emotion. They don't label their emotion. They don't notice their emotion. They don't remember an emotion related to an event. And so when people are alexithymic, they're experiencing some kind of distress, but they don't know quite what it is.
I have presented I'm also starting out in psychotherapy, and in a recent seminar I presented a graph that you have done. I don't know if you can call it a graph that you present many times in some articles and books, which is the one where you show the emotion, be it sadness, anger, or whatever.
Right.
Then there's a label to it, and I had a very, and basically that's like your model. Basically, how do you interpret emotion and how they
right.
And we had a very interesting talk about it, because my colleagues, many of them went, what was that? Why don't we learn that before? So it was very helpful to a lot of my friends, and to me also. That's why I presented it. So, and this links to me with some of the things that naturally lead to your other emphasis in cognitive therapy. For instance, I would like to talk about some of those, if you don't mind. For instance, in your work, you have broadened, in a way, the scope of therapy in cognitive therapy and talked more about validation, for instance. Right. So cognitive therapy has sometimes been criticized for being overly focused on techniques. Was there a point in your career where you also felt you could be on the verge of that?
Yes, absolutely. Yeah, good question. I published a book a number of years ago called Overcoming Resistance in Cognitive Therapy, and I have a chapter in there about validation, and so what happened was that I had a patient. I was very much focused on techniques at the time. You know, it was almost like a fetish: technique, 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 technique. And by the way, techniques are very good. But I had a patient who would just get more and more frustrated, and I realized that all I was doing was throwing techniques at him, and he was saying, "You don't understand," or "Let me talk." You know, in other words, he wanted to be able to talk and kind of work out in talking what his feelings and thoughts were. And so I realized that validation is an extremely important thing. Just give you an example. You're probably familiar with the great Spanish writer, Miguel Unamuno, who wrote Mist. He wrote a number of other books, but he had a series of essays called The Tragic Sense of Life. And in one of the essays, this is back, I think, in the 1920s, that Unamuno wrote this, and he has a story about, it actually goes back to the Greek king Solon back in the, I think the 5th or 6th century BC, 2,500 years ago. And Solon, the one who first developed democracy in Greece. But Solon, the story is, an old man is sitting by the side of the road and he's crying. And a young man who represents the modern, rational, social engineering thing, the young man comes along and says, "Old man, why are you crying?" And the old man says, "I cry because my son has died." And the young man says, "Why are you crying then over the death of your son? Crying will not help." And the old man says, "I'm crying because I know crying will not help." And Unamuno goes on and he says that we must learn to weep for the plague. We must learn to cry for the plague, not just cure it. And if you think about this is very much an attachment model in a way, I think. I mean, I think validation is an attachment concept. It's almost like touching or comforting, or I'm here and it's safe and I care, I have compassion, I'm always here for you, creating kind of a safe space in a way. And
can I just interfere there? And it also, for me, when I read your work and other people's work, validation also seems to bring some beliefs about emotions also.
Absolutely. And so we actually have correlational data that people who feel validated feel that their emotions make sense, that their emotions are not going to go on forever because they're expressing the emotion, they get validation, they feel less guilty about their emotions, or less likely to ruminate. So validation, where you help the person understand that you care about their emotion, you have compassion for their emotion. Validation is a social cognitive tool that changes one's beliefs about their emotion and helps them feel more comfortable with emotion. One of the things that I think we often overlook is how important social support is. That social support, when you're feeling down, talking to your partner or your friend or whatever, is so valuable at times. You feel we were not meant to be alone. We are not meant to be alone. The word idiot, I don't know what the word in Portuguese would be for idiot, right? The word for idiot is derived for the Greek word for somebody who lives by themselves.
I didn't know that. That's great.
It's interesting because the Greeks were, they believed in the polis, the community, and they believed that man was a social animal and that we were all connected one another. So there's a lot of wisdom, I think, in ancient philosophy of all the different philosophical and wisdom literatures.
So you bring in this the importance of validation to a tradition that usually might sometimes neglect it, which is great.
Right.
And also, you've talked about a little bit about it, countertransference. So the importance of using ourselves, not just throwing techniques to the other, but our own emotions. Tell us a little bit about that.
Well, again, it's kind of like, and I guess this is probably my unconscious roots in psychoanalysis way in the back, way back there. You know, I think the books are up there on one of the shelves. No, actually, Freud's books are downstairs. The cognitive therapy books are upstairs.
They're the superego over you.
The cognitive therapy is up here. The psychoanalytic down there.
Exactly.
Obviously the psychoanalytic people talk about transference and countertransference and resistance, and the cognitive behavioral people have been criticized for for dismissing that. And I've always thought, why should the psychoanalysts have all the fun? So I thought, oh, that's a challenge. I think we can do a pretty good job on transference and countertransference and resistance. So the countertransference thing, Alexandria, is that each of us comes to the work of being a therapist with our own theories about, I've got to get my job done. I've got to get the person to feel better immediately. This is a waste of time. The patient should always do what I want them to do. So we have certain beliefs that I think may often get in the way of the patient feeling that they can talk about their feelings, that they're feeling understood, they're feeling cared for. Just to give you an example, when I finished my training in Philadelphia and I was moving to New York City and I was finishing up with different patients and I wanted to get feedback from every patient about what they thought was positive and negative about being in therapy with me. And I thought, gee, all the patients are going to say what I loved is that you had an agenda, everything structured, you had homework and all that. Almost nobody said that. One patient said what really struck me. She said, what I really valued is I always thought you would always care about me and you'd always be there for me. And that really struck me as I was doing very traditional cognitive therapy at that time. But there was something about her feeling that the attachment was secure and that, so for example, you think about validation. Validation involves a sense of trust. And you imagine if you go through life and you can't trust other people and you can't trust yourself. Very much like people, for example, who are diagnosed with borderline personality, they have a very difficult time maintaining that trust. And they also have a hard time trusting or relying on themselves to be able to do things. And I think that that's often overlooked. So I think that transference and countertransference are very, very important. I mean, the patient is not going to get better if they drop out of therapy. And they need to feel that you're helping them accomplish goals, that they can trust you. And I think they have to feel that you genuinely care about them. We're not just providing a technology. We're not just giving a pill.
I read a study where I think a colleague of yours, at least she used your constructs, also said that she found that cognitive therapists had usually demanding schemas on their patients.
Right. Yes. Right. Yeah. That's some therapists, and also about themselves. That the demanding that things have to be done a certain way on my agenda can be helpful, right?
As 𝗔𝗹𝗲𝘅 would say.
Right. So it's I think it's important to look at your own concepts about each patient. Like patients who are narcissistic tend to, the therapist tends to respond with a lot of anger and resentment, and and I think that comes across. But if you think about narcissism as a way in which this person copes to avoid injury, so if the person comes at you with their narcissism, they're superior and you're inferior, and then you either show lack of interest or you're critical, they're going to then say, well, see, I really can't trust this person. So I think it's hard when you're a therapist not to take it personally, not to catastrophize, not to overgeneralize, But I feel like I'm always learning from my patients. They're my best. You talk about all these other teachers. It's my patients who've taught me more.
Yeah, it's interesting also what you said about your ex-patients. They supported this idea of the importance of the relationship and validation. And there's this great book, well, co-edited by Norcross, about the relationships at work. And repeatedly these studies come out saying that the relationship factors seem to be the highest ranking in the outcome, explaining the outcome in therapy.
Right.
I would like to play a game with you. I'll play devil's advocate here.
Sure.
Because there is still a lot of discussion over the issue of mechanisms of change in psychotherapy. And there's been, you were talking about, well, at least here cognitive therapy can be a little controversial and be beat on a little. Because there has been some controversy about the mediating effect of cognition and outcomes in psychotherapy. Being more specifically, I know people like Kasdin, who he reviewed the research and concluded that the treatment improvements could occur without changes in cognition, apparently, or at least without implementing cognitive change strategies. Stephen Hayes has said many times that the science behind the traditional model is flat out wrong. So you're a scholar in cognitive therapy. How do you feel about all of these attacks?
Well, there's research supporting every point of view that's been advanced. So, what I think is, when you say it's not necessary, the change in cognition, here's my view. I don't think there's anything that's necessary. But I also think that there are a lot of ways of making change. And so, to be really fair about empirically supported treatments, that we certainly know that cognitive therapy is effective. We know behavioral activation is effective. We know that exposure therapy is effective. We know that ACT can be effective. We know that there's now some evidence that compassion-focused therapy is effective. We know that interpersonal psychodynamic psychotherapy can be effective. We know that transference-based psychodynamic therapy, which is psychoanalytic, can be effective. We know that DBT can be effective. Emotion-focused therapy can be effective. We know medication can be effective. We know social support can be effective. We know even that religion can be helpful to people. There was even a study many years ago, and there was a review of exorcism. That exorcism can be, exorcism has one hell of a placebo effect. So we know placebos are effective. We should all just go get exercise. So I think frankly a lot of us sort of get caught up in like our brand, and I have to confess that that's the way I've thought at times. But I think my view of it, Alexander, when a patient comes in to see me or my colleagues, they're not coming in because they want some, rigid thing. Model. They're coming in because they want to get better. And there are times I'll use, cognitive therapy. I'll use metacognitive therapy. I'll use behavioral activation. I'll use some mindfulness. I'll use, acceptance. I'll use anything to help a patient. This is not a religion. I think that we have to recognize that, there's nothing that's necessary. Certainly, ACT is not necessary. People were getting better before there was ACT. DBT is excellent, but it's not necessary. There are people who get better in schema-focused therapy and transference-based psychodynamic therapy. So the idea of something being necessary, there are a lot of ways of helping people.
So it's more like you're using yourself with all of the experience, of course, you've accumulated from all these models.
Right, and I think part of that is trying to figure out what is this patient's or this individual's problem, and how could we find something that matches the patient, rather than saying, I always do this with every patient, which is unfortunately how some people approach doing therapy.
We passed through a bad phase of manualized treatments.
Right. I had lunch with a psychoanalytic psychiatrist in New York about a year ago, very senior person in the field, and one of the top people in the Psychoanalytic Institute. And I was describing my emotional schema model to him. Mm-hmm. And he said, "Oh, Bob, you're the biggest phony going. You're just psychoanalysis." I said, "Well, coming from you, I'll take that as
a compliment." Exactly.
But I'm not. I mean, I certainly think that there's a lot to be learned from our colleagues in all fields. By the way.
Just one last devil advocate's question still, because I can imagine that at least people like Aaron Beck, they suppose that when they created direct cognitive interventions, techniques and stuff, that the outcomes would be considerably better. But the meta-analysis seemed to point out to this dodo bird verdict. How do you think even Beck feels about this?
I don't know. I mean, let me tell you about Beck. Beck is going to be 95 years old this summer, right?
Yeah.
And so we often think that somebody who's 95 is not functioning. Beck is still functioning at the same level he was functioning at 30 years ago.
Incredible.
I sent him an email describing my ideas about jealousy, tying jealousy to evolutionary model and a cognitive model and an attachment model. And he wrote back, this is like 6 weeks ago. He wrote back, he said, "Oh, Bob, you might be interested in this paper I just published in December." And he sends me this paper. I forgot what journal it was. It was a very top journal. And it was one of the best articles I have ever read in my entire life on the cognitive model. It tied in evolutionary theory, it tied in neuropsychology, it tied in socialization, it tied in trauma history, it tied in the cognitive model, tied in information processing. I mean, it was such a brilliant paper, and I'm sitting here thinking, this guy is incredible. He's going to be 95 years old, and he's writing an article that is absolutely brilliant. And I am not exaggerating. I was talking with, Stefan Hoffman about this, and we were both like, can you believe this? This guy is incredible.
But
it's a great thing
now
to
you
see.
have to tell us what's the name of this article. Do you know?
I would have to dig it up.
We'll find it up and then I'll put it on the description.
Yeah, right.
It wasn't the generic cognitive model, no?
This is an article that came out in December, I think.
Okay.
Just a few months ago. Yeah.
Okay. So I guess he's still, and I know he for last years he's still doing research. Still, I mean,
right. On schizophrenia, right? Yeah,
exactly. Right. So we're just finishing off, but I'd like to ask you, because you've also written a number of self-help books on worry, anxiety, depression, and employment. What's your opinion of? You've talked a little bit about this. You've talked about the feeling good. When you say that about the David Burns self-help book, I remember,
it's an excellent book.
Yeah,
superb book.
I remember. I think it was Stephen Hayes that once wrote a phrase that I always remember, that maybe the objective was not feeling good, but it was feeling good. Well, do you understand? Like more like being able to experience the whole range of feelings. And I connect this with your work, actually.
Oh, I see.
Yeah.
I haven't heard that. Yeah, and I think here's the takeaway point. I think with all the different people that you're interviewing and people that we read about and stuff like that, it's, I think, to recognize that a lot of different people who often are arguing with each other and whatever, that we can learn from each other. I think we should be open to ideas that enrich the work that we do. If we can learn from each other, our goal should be to help people and to understand people and all that, rather than to say only what I do. So when you say that is something necessary, well, people were getting better before there was psychology. I mean, it wasn't like 1,000 years ago, people didn't get better. They got better. In fact, most people who are depressed get better without therapy and medication. I mean, that's actually one of the challenging things, that something like 60% of people are going to get better from depression with nothing. How do you explain that? It's the nothing what you have to understand. What are they doing? They're connecting with people. They're getting back into their lives and so forth. There's been research done on borderline personality, and we often think about borderline personality as absolutely severe, and you can't change it without really. And I think there's some wonderful work that's done in DBT and schema-focused therapy and psychodynamic transference-based therapy. But the fact is that, 8 years later, about 80% of people who were diagnosed as borderline are no longer borderline without treatment. Yeah. Irrespective of any treatment. So people get better.
Yeah.
And what I think the challenge that we have is to find out what are the natural cures in people's lives, changing beliefs, changing their behavior, changing their relationship, changing their environment, and so forth, finding some new meaning.
Yeah, and how can we promote that also in our field? Yeah.
Right. And so what we should be doing is learning from each other.
Yeah.
And learning from our patients.
Yeah. So I have one last question for you, Robert. It's been such a great pleasure. I'm asking this to every one of my interviewees. Yeah. What is the advice you wish you would have received when you were starting out as a psychotherapist?
You'll never stop learning.
Better accepted.
Yeah, I mean, and I think the great thing about it, Alexandra, is that that if we approach that we're always going to be learning and changing. I was talking to a top neuroscientist, and he said there are two kinds of theories. This is an old concept. There are two kinds of theories: theories that have been proven wrong, and theories that have not yet been proven wrong. But that's the nature of science, I think, is that we're constantly building and changing, and even physics today is different from physics 100 years ago or 200 years ago.
Yeah, Stephen Hayes told me a funny story that he works on the psychological flexibility model, and he usually tells his people in supervision, sometimes he looks at them very seriously and says, and remember, psychological flexibility is wrong. Okay, now go home. So,
that's fun.
Bob, it was such a great pleasure. Thank you so much for this opportunity.
Nice to meet you, Alexander, and good luck with your work in the future, and look forward to keeping in touch with you.
Thank you.
Take care.